Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. As we near the end of our podcast series on pain management for family physicians, we're bringing you a nuts and bolts look at stepping down opiate doses in your patients. Yep, today we're talking tapering. In particular, when is tapering indicated and when is it not? Does it constitute prudent and thoughtful medical care? Or is it just a question of keeping your nose clean with your college? Is it sometimes medically necessary to wean a patient down and even off opiates? Can stepping down and even discontinuing patients improve their health? Or can it be dangerous? 3 pain specialists who wrote into the Canadian Medical Association Journal last winter certainly think so. They said they'd heard of deaths in patients who'd been tapered or discontinued and had sought replacement medications from street dealers. By then, they'd lost tolerance and subsequently overdosed and died. Is forced tapering ever a good idea? What about stable patients on doses above the 90 mmE ceiling the McMaster guideline recommends and colleges appear to have mandated? Suppose you have so-called legacy patients doing well long-term on opiates where they've not done well on lesser therapies. Suppose they want to be left alone with a therapy that works for them without downsides, especially when they've exhausted their options. Even in less complex and less dire situations, how do you keep your patient safe and comfortable through step-downs, unbothered by withdrawal symptoms or the return of severe pain? How exactly is tapering done? Slow or fast, just to get it over with? Is there a one-size-fits-all approach, or should tapering plans be customized for each patient? There's very little proven guidance out there about how to taper. There's very little science about how patients respond. There's even less science out there on the benefits of tapering to patients. We seem to be making it up as we go sometimes. No wonder, then, that reports suggest that doctors approach stepping down patients on opiates very differently. And indeed, we don't seem to have a standard to follow. We have a lot of pedagogy out there about weaning opiate doses. Is pedagogy going to help you in dealing with that patient in pain across the desk from you? I doubt it is, and for that reason, I have Dr. Alan Kaplan joining me today. Dr. Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto, and he's going to tell you what you need to know about tapering. Dr. Kaplan, thanks for joining me again, and it's good to see I haven't worn you out.
Thanks, John.
As I said to you in an earlier episode of our pain podcast series, Dr. Kaplan, this is possibly the first time in history where a therapy that appears to work well without significant downsides is nonetheless hustled out of the formulary, despite there being very few good alternatives, and for some patients, no good alternatives at all. But I know you believe tapering has a place in chronic pain care. And I want to hear about that. We all do. Let's get straight to the bottom of why and when to taper before we get to the meat and potatoes of how. Let's put aside what the guideline says and what the colleges say. I know the college part is a dream, but let's pretend it doesn't matter what your college wants for a moment. So what are your thoughts, Dr. Kaplan? Should every patient on opiates be weaned off them? Should anyone be weaned off them?
So let's, first of all, make sure our terminology is consistent. Tapering, weaning off, all mean a little bit different. So tapering means coming down off the therapy to the lowest effective dose. I think there's no product we would not want a patient to be on the lowest effective dose. Weaning off means tapering to the point of stopping, and that's a fairly arbitrary decision, and I don't think I would support that. On the other hand, there may be some people whose pain conditions have improved or who make a decision consciously they no longer want to be on opiates because of the side effects. So should everybody be tapered? I think everyone should be on the lowest effective dose of the drug to help them. If you have an asthmatic, you want them to be on the lowest dose of inhaled steroid to keep them controlled in their asthma to minimize the side effects of inhaled steroids. I think that's still a fair statement for any medication we use to make sure that it's not causing side effects but causing efficacy. Now, who are the people that should be tapered? So if we say everybody, and what's the speed, that's of course what the question is. And I think we probably have to spend 1 second on just exactly what the guidelines did say, because this is going to form the basics of part of the conversation. And I want to actually quote it to you. It's recommendation 9 for you to go back and read them. And it says, for patients with chronic non-cancer pain, so again, we're talking about chronic pain, not cancer pain, who are over 90 milligrams of opioids or more, of morphine equivalent, they suggest, they don't order, they suggest tapering to the lowest effective dose, which could include discontinuation, rather than just sitting the way you are and not doing anything. It's very important that this was a weak recommendation. In other words, it was not a strong recommendation. It's more of a suggestion. They then go on to actually clarify this to say that some patients may have a substantial increase in pain or a decrease in function that will persist. They give it a timeline of about a month, even after a small dose reduction. In that case, tapering should be paused or even abandoned if the patient is obviously not doing well. And this is the part that's been missed by some of our colleagues and being missed by the college in their excitement to get people off opioids and in the unidirectional approach this has had. Because what's happening, as Dawn had, as you said in the introduction, is this has been taken as gospel, and patients are being taken off their medications even though it's causing them harm, decreasing their function and increasing their pain.
So what about forced tapering? We know it is happening. I know personally that it is happening. There are all kinds of reports that it's happening. I have no reason to doubt them. I think you've heard of the reports as well. If medical colleges are determined to see people tapered, what options do doctors have?
Great. So it's a matter of what we're talking about again. So the recommendation is to consider a taper in patients who are on higher doses opioids if they're stable, if the pain condition is stable, if there's no reason not to do so. So that doesn't mean everybody. Remember, they said, again, if someone has been tapered and is doing poorly, then you should consider abandoning this idea. And it's for someone who is stable. So what happens if you force tapering? Well, that means people have taken this initiative too far. And they're forcing people to do poorly and to decompensate. You wouldn't take someone who's on insulin and reduce the dose of insulin arbitrarily, because then the sugar's going to go up and you're going to have complications. It's the same idea. Now, what's happened with involuntary tapering is people who are suffering will then go on to deal with their suffering in a variety of ways. Some of them, as you mentioned, Dawn, have gone to the streets to buy medication. That's bad economically. It's feeding the wrong population of people out there, and of course can even cause death because they may get something they didn't expect to get, or they've lost the tolerance you just talked about. Other people have decided they're not going to do that, and instead of trying to work with their doctors who are now afraid to use opioids, this has caused them to become so unfortunately harm themselves, and we've had a number of suicides because of this. And that's just truly a scary, scary thing. And I'd like to point out the article that you wrote in the National Post, Dawn, that talked about you being told by other pain patients and even yourself having a potential for a suicide plan if this was to happen. That's a scary kind of thing to have to put well-meaning, honest patients through. It is not mandated by the McMaster guidelines. They said it's to be considered and to be offered, but not to be forced if the patient's not doing well. And in fact, while the colleges initially were mandating this, now they deny they're actually requiring it. So as a clinician, you do not have to do it. You have to think about it. You have to consider it. You have to document why you've done it or not done it. And you then have to make a decision how you're going to approach that individual person in front of you. In addition, the dose is a bit of an issue. And we're talking about people on 90 milligrams of morphine or more. But as you said earlier, those legacy patients who are on very high doses, taking them down very quickly to a dose of 90 milligrams can be an absolute disaster for them. And I think we have to recognize that even those patients, we may want to consider it and try it, but you have to go very slow.
I don't know that we can get into the weeds on this here, but there appears to be double talk coming from many, if not all, colleges across Canada, where they're saying that they're not mandating tapering, but they're acting as if they are mandating tapering. And I'm not a physician, but it would appear to me that most physicians must be awfully confused and perhaps pretty anxious about this. I'm just wondering what the end game is. How do you see this playing out, Dr. Kaplan?
Well, I think that there's a reason behind these recommendations, and the recommendations have to do with some of the harm that's occurred with opioids. And while we've talked already in this podcast about the fact that most of the harm from opioids and the deaths that are occurring are happening having nothing to do with prescription medications at all. But there is some responsibility here in terms of what's got out to the street based on what's been prescribed by well-meaning clinicians. So this caution is very appropriate. And once again, I'll analogize to other conditions. If we talk about diabetes, for years and years and years, we used sulfonylureas as a treatment for diabetes, and we've learned that sulfonylureas actually deplete beta cells over time and actually do harm to the pancreas over a long time, and therefore they're a last-ditch therapy for diabetes. So you would want to consider stopping a sulfonylurea for diabetes, but the good news is we have a whole bunch of new medications to replace the sulfonylureas. We have insulin if we're really stuck. In pain management, it's a little bit different. And in addition, while there are side effects and concerns, the patient has to also decide which problem is the bigger one for them, the side effect, whether it's constipation or nausea, and unfortunately occasionally cognitive issues, versus the pain they're having. And that's the issue we have to have with the individual patient. What we're doing, though, is we're mixing up the patient and their issues with the other population of people who are not legitimate patients or who are selling or misusing or unfortunately have an addictive disorder. And that's what makes this so complicated.
Right.
And as far as your question, sorry to answer your question about this sort of almost double standard by the colleges. So again, they made the point that this is relevant. They've made the point that there's some evidence that doses above 90 have a little bit more concerns than less than 90. There used to be 200 with that number in terms of the watchful dose, but there is some reason for that number. But that being said, it's not a line in the sand that must be crossed. And for my colleagues out there who are trying to figure out how to do this, I can make it fairly simple. Your patients who are on opioids, you in your chart and with the patient, you document a conversation about where they are, how they're doing with pain and function, how they've got to the situation, and a conversation about consideration of tapering. Most patients are resistant to it, but once you give them the concept, and what I say is sometimes the opioids can do more to you than for you. And let's try taking it a little bit down and see if you actually do okay with it. And it's interesting, Dawn, that the majority of patients, not all, but the majority actually are able to taper to some degree down. That's probably indicative of the fact that our dose was escalated too high initially. Those people that can taper down are very happy about it, and those that can't, the key message is don't force them down further and destabilize their life.
Right, thanks. Perhaps an unintended consequence, and it was, I think, unexpected when I saw this happening, are stable patients, long-term users of medical opiates who are doing very well on them, who read the media or who watch the news and begin to be frightened by their therapy and decide, oh gosh, this is going to kill me. The news says this is going to kill me. The news says this is going to turn me into an addict, so I better come off it. If that patient were to come to you, Dr. Kaplan, and that patient had been doing really well for, I don't know, let's say 10 years, on an opiate that is at least 200 MME, which was the recommended ceiling in the old guideline, the 2010 guideline. So let's just say that patient is on 200 MME or perhaps more, doing really well, has no unmanageable side effects, just has this media-induced fright. What would you suggest to the patient? What would the conversation sound like that you would have?
Great question, Dawn. This goes back to a conversation with the patient about what their fears are, what the pros of any medication are, and the cons of any medication. I think it's a very nice opportunity to talk about the fact of reassess how they're doing. Has anything else changed in their life, how they are emotionally, how they are physically, how they are with other comorbidities of their illness, and whether, in fact, there's any concern they may have about their medications personally rather than just what they're reading in the paper. I think that's a nice opportunity to consider, well, maybe it's worthwhile doing a very slow attempt at reducing the dose and seeing how you do. But what I will tell them very clearly is too fast, too much is going to harm them. And they're not going to do well, and they're going to feel badly, and it's going to affect their life adversely. So in their enthusiasm to get off the medication because of these fears, they can actually do themselves harm. So that conversation will occur at saying, why are you afraid? What's the evidence for this? And a review of that evidence, and we've talked a little bit about that already. And let's have a look and see whether, in fact, you could perhaps manage on a slightly lower dose, and whether, in fact, you feel better on a lower dose, because that actually does happen, or whether, in fact, you are doing worse, in which case that's a mistake for us to try to taper any further.
Okay, so let's talk about the fundamentals. Let's talk about the math, if you will. How much does the dose get lowered, and how fast? Is this a one-size-fits-all thing, or is this something that's customized patient by patient by patient?
I think the answer for all medicine decisions are it should be individualized to the person in front of you. I think there's a lot of factors that go into how fast we taper. But the key one, and I think probably the overwhelming one, is that you are going to induce some degree of withdrawal and some worsening of pain when you taper. And how much of it's withdrawal and how much of it's pain depends on the underlying person, the dose, and the condition. What happens for the most part, if someone can have a successful taper, is as you reduce the dose a very small amount, I'll talk about the amounts, there will be a slight worsening in the pain that will last for 1 to 2 weeks, and then it goes back to what the baseline was. Now, that's very scary for a patient, and I tell them this is going to happen. We talk about using other therapies to try to maybe make a difference so the pain is not worsened too significantly. And there will be some little bit of withdrawal effects that occur as well, and we can use medications to assist with the withdrawal as well. If that pain is very, very significantly worsened, then it's not a good decision. If it's tolerable, then going through that and giving that 2 to 4 weeks each time, give them a chance to get through that initial withdrawal/worsening and then stabilize, is often done successfully. So that's the timelines I talk about. I don't go any faster than 2 to 4 weeks at a time. And then the amount. I've heard recommendations of 10 or 20% at a time. That's preposterous. It takes a long time for those opioid receptors to settle down and downgrade. And we have to recognize that we actually have to reteach the opioid receptors in the body to be less sensitive. So slowly and small amounts are the key amounts. Now, how much will depend on where they're starting from. So as you can imagine, someone's on a very high dose, a small percentage is a small number of milligrams compared to that same small number of milligrams, which should be a high percentage of a smaller dose. So I'm talking about numbers of sometimes as little as 1% at a time, and often about 5% is the number that I use. Recommendations in the guidelines are often talking about 10%, which I think is still a little bit too fast. So for me, it's usually numbers like 3 to 5%, but frankly, it depends on the math. I want the math to be easy. So I take the number of milligrams, I take their tablets, and make it something where I can conveniently cut out an easy dose that's replaceable to make it easy. So slow but steady really here wins this race. The only time I go fast is for patients who I don't think are taking the medication at all. And what we're talking about here is someone who I believe is actually selling or misappropriating the drugs, and unfortunately that does happen. These are patients who come in on a medication dose that should show positive urine drug screens, and after checking with the drug screen and making sure it's accurate, if there's no drug in the urine at all, and we double-checked it and made sure that it's accurate screen, if there's no drug in the screen, then they're not on the medication at all. And at this point, tapering is a different conversation. You're actually just no longer supplying. But other than that, why on earth would we make somebody suffer with withdrawal and pain by going too fast?
I want to pick up a very small detail in something that you said in answering that question, and I frankly haven't got a clue about it, and I think that probably it's going to come up with patients who are being stepped down. It's the business of the 2 weeks of pain that seems to come back, the 1 to 2 weeks, I think you said, and then disappears. What's that about? I mean, what's going on with that?
Well, my understanding of it is it's got to do with the opioid receptors in the body. And as you fill receptors in the body responds to having the receptors filled by potentially making more of them or sensitizing the receptors so they work a little bit more efficiently. As you decrease the filling of the receptors and you decrease their stimulation, they tend to downgrade. It's much like smoking cessation and nicotine receptors. As you don't smoke for longer periods of time, the nicotine receptors become less sensitized and the cravings are sometimes a little more. I'm not saying opioids are cravings, it's the same thing at all, because it's not. But it's a matter of just the body's, it's a nervous system issue, and they're a little less sensitized. So that's what we hope are happening, is that the body becomes a little less tolerant to it, and it's not dependent so much as tolerant, and therefore we get used to being okay on the dose that we're on, because usually the amount we're on is plenty to saturate opioid receptors in the body.
Okay. You have mentioned that it's probably not possible to avoid at least some withdrawal symptoms. Why is that? I mean, if you were to go really, really slowly, couldn't you avoid withdrawal symptoms?
That would be nice, I suppose. And I suppose if you go slow enough, that's possible. And I suppose it depends on where you're starting from. It's something that's got to do just with the size of the long-acting pills. I mean, so if you're starting on 90 milligrams as a dose, for instance, let's say you're using 100 milligrams of oxycodone just to be a round number. You can't decrease it by more than 10 milligrams at a time, so that's going to be 10%, no matter how you bite it off. So it's just technically hard sometimes to get a small enough reduction to avoid that. But I suppose if you were to be patient enough and work with this over a period of time and go slow enough by literally 1% or something like that at a time, you could avoid withdrawal entirely. A lot of this is also the perception and the fear of the patient going into this. If we're expecting a terrible amount of pain, you're probably going to have it. If we can reassure that we're actually going to be able to get through this together, patient-clinician interaction, we might be able to do this in a successful way. So clinicians, as you're doing this, be positive to your patients, saying, we're going to work through this together. I'm not going to leave you to suffer. We're going to take care of this together and make sure that we're doing this in a way that's safe and comfortable for you. Withdrawal does not have to be a horrible thing. It can be a minimal thing as well.
Could you run down the symptoms of? Could you run down typical withdrawal symptoms for us? I don't imagine that a lot of GPs have dealt with it, so maybe it's worth running them down.
Sure, and that's what I was going to say. Exactly, we're thinking the same line. So withdrawal symptoms can be more severe or less severe, and more intrusive and less intrusive. And the most common is going to be probably loose stools and diarrhea, because opioids are constipating. There's going to be a little bit occasionally of excitation. Sweats are very common withdrawal symptoms as well. Vomiting may be another withdrawal symptoms if it's done too fast. So there's going to be some change in the bowels, for instance, as a withdrawal symptom, which can be a very minimal symptom and just can be anticipated by looking at the laxative use or the anti-constipation therapies we're giving to the person who's on opioids and considering adjusting those as you go so you suddenly don't get a bunch of diarrhea, for instance. That's probably the most common withdrawal symptom that I'll see. Other than that, pain is often one, a little agitation is sometimes done, and the sweats can be there if it's done a little too fast.
What is the point of giving clonidine?
Clonidine's major advantage, clonidine is an antihypertensive that works on the alpha receptors, and it's been shown to actually decrease the sweats that occur from withdrawal. In addition, it may also be some kind of positive reinforcement in terms of the nervous system to opioids and improve the efficacy of the opioids to some degree. So I think it improves the opioid efficacy at the same time as decreasing sweats. I
can see that there's nothing I'm going to be able to stump you on today. Let's just go back to the question of how everybody's doing this differently, because there doesn't seem to be a standard. You made the point that you would prefer to taper patients, not the ones that you would taper quickly because their drug screens show that they're not using the drug anyway, but the patients who have been getting benefit from the drug, you made the point that you would prefer to taper them more slowly than the guideline recommends. It seems to me that other than the new revised standard in British Columbia, we don't have another centralized document. We don't have another centralized guideline to go by, and you're saying that already you differ from it to some extent. What's a doctor going to do? I mean, how does a doctor know what's the best advice?
Well, I can understand why the confusion is there, as you're alluding to, Dawn. It's this pressure to taper down, and it's one more thing for a primary care doctor to worry about in their day. So here I am going to talking about 1% at a time or something like that. Well, 1% every 2 to 4 weeks is hundreds of weeks, isn't it? And I can understand why that sort of it could be dreaded by a clinician thinking, I've got hundreds of weeks of work in front of me over the next time. I want to go faster, and I certainly get that. But I think we have to remember why we're doing this. We're doing this to see what the lowest effective dose is for this patient, and we're not punishing them. We don't want to cause them discomfort or harm or have bad things happen to them because we're doing this. We want to work with them. Some patients may be ready because their pain is under good control to do it a little bit faster, and some, to reassure them, I'll do it much slower. Sometimes we do it very slow, and patients say, you know what, I can go a little bit faster now because I had no problems at all with this very slow step. So I think you really have to do a little bit of step back and look at the situation that you're doing and see how it's working. In addition, we can use adjuvants and things to try to improve the pain management in different ways than just other opioids. You know, we have all the different neuropathic pain medications we can use. We can talk about anti-inflammatories. There's been a lot of work with cannabinoids now being added in as an assistant to be able to taper down on opioids. So we can treat pain differently at the same time as reducing the opioids, and perhaps have a pain reduction and a reduction in opioids at the same time. And there is a point to considering this, because what's amazed me is that there's a significant number of people who feel better on a lower dose. And that's what we have to remember. That's what we're looking for here. We're trying to make people feel better, not worse. We're trying to make it safe for them so there's no downsides. And remember, some of the adjuvants we use also have downsides. So if we use high dose of a gabapentinoid, for instance, that can make them sedated. Be careful you don't cause side effects with the other adjuvants that we think are quote, safe, because sometimes they have issues as well.
Okay, and you've already said that at the end of a taper, at the end of even a discontinuation, if and when pain returns, you've said that the taper should be reversed, or if we're in the middle of it, it should be paused, potentially abandoned, as the guideline also says, and the colleges seem to be saying that and saying something else at the same time. I just want to clarify, if a patient has clearly, in his view, done badly with a taper, is the physician more or less obligated to reverse that taper and put him back on his on a dose where he feels okay again?
Well, I think there's college obligations, physician, patient obligations, and moral obligations to come into this. The college has been interpreted as being quite black and white on this, that everyone has to be tapered. And to be fair, speaking to people at the college and what they've since published in things like their updates, they are saying that they're not saying that. So don't clinicians feel like you have to do this because the college will come down on you. Of course, there are provinces like BC that have made this mandated and so on, which, you know, it's actually difficult if you're a BC doctor because it's become quite difficult there. It's not quite that bad everywhere else yet. If you have had a patient that you've tapered and they've done poorly, then take them back to the dose where they were comfortable. Maybe not back all the way to where you started from, but bring them back up a little bit and give it a pause. And give this a few months pause and a break for the poor patient who's suffering with this, and then maybe you agree together to try it again. Again, if it doesn't work, you can stop once again. Because I think that there's some time in here. Time is a big factor in this, and that's why I talked about the speed here. I'll often taper for a little while, and the patient will come and say, well, can we take a little break on the taper right now because it's just been a little tougher to deal with the difference in painkiller? Well, my answer is absolutely. As long as this is a stable patient that is doing well and I have no concerns about how they're using their medication, then absolutely, I'm not trying to make this person suffer. I'm not punishing them. I'm trying to work with them to be on the lowest dose that's effective for them. So we say, let's give it a break. You're okay where you are? Yes. Okay, let's stay here. Let's reassess this in 2 or 3 months. Okay, life is better. Things are different. You're not stressed with your spouse or a job thing. Things are better. Let's try it again then. This takes years to occur. This is not going to happen overnight. This is not a fast thing. And my colleagues out there, just remember, there's no pressure to get this done tomorrow. There's a pressure to think about it, to document you've thought about it, to document your trial, and to work with the individual person in front of you. Because remember, one of your dictums is to do no harm. Doing no harm also talks about not overusing medications, but also says not to underuse when we talk about pain medications.
I just think that's a great place to end because it's kind of a summary of all the things to think about, and perhaps the only thing to think about, do no harm. You're trying to help, not harm. So I was going to ask you a question about follow-up, but I think you've already dealt with that. You've said 2 to 3 months is a good time to follow up, and you've also pointed out that this is an ongoing thing. A family physician who's dealing with a patient over the course of the physician's career or the patient's life, this is always going to be an issue when a patient has chronic pain. So I guess the accepted protocol for follow-up is whatever seems best between that patient and the doctor.
Well, let's talk about interval. I mean, I gave you the idea of 2 to 4 weeks for the reasons I explained, because things get a little worse for the first week or two, and then things stabilize again after that for the person that you're successful in tapering. There's a lot of rules about how often you're supposed to see a patient on opioids, and the sort of quote rules are, you shouldn't be longer than 3 months between visits, and you shouldn't give more than a month's therapy at a time, even in a stable patient. And if you're going to give 3 months, you should give 1 month at a 3-month prescription with 1 monthly partial fills. I was thinking about this one day in a patient of mine I was seeing who was doing quite well, and it occurred to me to ask them how long it took them to get to my office. Because as a pain doctor, I get referred by other clinicians, and sometimes they can't find a doctor local to where they are. And one person explained to me that it took them over 2 hours to get to see me on public transit. So these poor patients were taking 2 hours to come to see me. They get there, they would spend a little while in the waiting for me. The time with me was relatively very short. It could be a 15-minute appointment because things are going well and we didn't have anything to really change. We're just reassessing, and I'm really seeing them just because they're an opioid patient. And that's such a sad thing to think about. And it really made me stop and think about the rules that I was giving my patients who were on opioids based on the fact that I had to be so almost neurotic myself about how I'm looking at opioid patients. We have to see them, we have to assess their function, we have to assess their pain, we have to consider doing a urine, and we should be doing those things. But I think we have to divide up our patients between what patients who are stable, successful in their treatment, low risk of misuse, there's never been any issues, versus those people who have a little bit of a higher risk based on the opioid risk tool we talked about earlier, those people who are breaking rules, those people who are asking for early refills, and therefore we have concerns about their behaviors and what's going on. So that stable patient I will not see quite as often. I may let them go 3 months at a time, but I'm cautious about not giving large volumes of opioids at any time, not so much because I'm even worried about the patient themselves, but sometimes perhaps a family member or something like that could get into the medications if proper care isn't being taken.
That's great. I think very few doctors appreciate what some patients go through just to get to a medical appointment. I'm glad you pointed that out. I think there are some patients who are traveling further than that. I think it's also important to note from the point of view of the patient that getting shorter period prescriptions and refills is expensive for patients. It's expensive in at least two ways. You've got to pay a pharmacy fill fee every time you fill a prescription. So if you had been paying a fill fee every 3 months, you now have to pay 3 fill fees, one a month. And also the access is a problem for a lot of pain patients. Maybe they don't drive. Maybe they have to get somebody to drive them. Maybe they have to take public transit. Some people actually are taking planes these days to find pain physicians. And pain patients are usually not rich. Often they're on disability pensions. It's difficult for patients, and when limitations are imposed on them that they feel maybe arbitrary, it becomes more difficult. So I just want to thank you for being sensitive to that and pointing that out to other physicians. And to thank you generally, because I think what you said puts things far more clearly than they have been. This has been a complicated mystery to people. They're getting double messages or triple messages, and both patients and doctors, I think. And so I think that this has gone far in clarifying things. Thank you.
Thanks, Dawn. Thanks very much.
Join us next time for something a little different, a chat between Dr. Kaplan and his colleague, Dr. Robert Hopman, about the use of cannabinoids in chronic pain. So if there's a fog around cannabis as a pain therapy, we aim to burn through it for you. So please join us. I'm Dawn Rae Downton. Hope to see you then.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.